evening. My name's Claire Lomax. I'm a clinical psychology and program director of the clinical psychology training program here at Newcastle University.
And I'm Stephen Holland. I'm a cognitive behavioural psychotherapist working out of the psychology clinic based at Newcastle University, which I think Claire's going to explain a little bit about in just a moment.
So what we're going to talk about this evening is, as Laura said, overcoming needle phobia in the age during a pandemic we're living through at the moment. And as psychologists, we're going to take a psychological treatment perspective on this. So I just wanted to start by introducing you to our clinic that we run here at Newcastle. This is the Psychological Therapies Training and Research Clinic. We are a university-run clinical service for students, and this is some of the team you can see here in our lovely new building on the campus with our clinic rooms in the background. As lots of you know, common mental health problems can be treated really effectively with a talking therapy called Cognitive Behavioural Therapy, which is the kind of therapy that we work with. And the people in the clinic, all the clinicians use CBT, and we're a range of clinical psychologists and CBT therapists. We also have lots of trainee therapists working with us as well. And we see students on campus. That's our clinic. It's usually for about an hour a week for between 12 to 18 weeks. And we usually work with trauma, anxiety and depression. These are the common mental health problems that you'll have heard of and know. And one example of the kind of problem that we'll see is phobias. That's a really common type of anxiety problem. So just to think in a little bit more detail about what is a phobia. Now, lots of you will have heard of and use the word phobia, that you're phobic or that you've got a phobia. And we all have things we're scared of and anxious about, but what actually is a phobia? Going beyond just the normal use of the word, we can diagnose it in the following ways. There's certain ways that we can say that you've actually got a phobia diagnosis. As you'll all know, it's a fear or anxiety about a specific object. It might be an insect or an animal, or it might be a situation such as flying or heights. And the other criteria that we use to diagnose it is that it should be greater, the fear or anxiety should be greater than it should logically be, so there shouldn't be actual real danger involved. So we probably all know the statistic that people find are more scared of public speaking than of death, but actually we all know that public speaking actually isn't dangerous, although we all fear it and are anxious of it. But actually the fear should be greater than it is logically, and you'll do everything you can to avoid or escape or get out of it. And to meet criteria for a diagnosis of phobia, it has to get in the way of your normal everyday life. So it's stopping you doing things and achieving your goals, or you manage it but with great distress and upset. So these are the kind of diagnoses for phobia. And we know it's really common. And so I think we were looking before, there were about 500 of you here in the team in the group today. I think it's 500.
I think we're now up to over 700.
Okay, so my stats now, how many is that going to be? That is going to be about 30 of you roughly are going to be sitting in the audience experiencing a phobia, having experienced a phobia statistically. So,
with that being said, yeah, we given that there's such a big group of us here this evening, we thought it would be interesting to do a couple of polls. And we just wanted to get a sense of the range of types of phobia or common fears that people might experience. So the first thing to keep in mind is that these polls are completely anonymized. You don't have to give any personal information. But in a moment, I'm going to ask Laura to bring up a couple of options. And the question that we are asking you guys, first of all, is what are you scared of? And we want to kind of group our fears, the common fears, into several categories. So in line with what we're doing this evening, it might be that you yourself experience blood or needle phobia or fear of. But then also it's really common for some people to be scared of particular animals or insects, dogs or cats, wasps, birds, anything in particular really. Snakes is quite a common one. Being scared of crowded places, so your supermarkets, your high streets, or your kind of entertainment venues, pubs, music gigs. Heights, that's certainly one I can relate to, which is weird because I'm 6'6", but yeah, going up ladders or high places. Social situations, which might range from just feeling a bit shy meeting people right up to quite crippling anxiety when you're having to function in a social setting or public speak. And flying is fairly self-explanatory, but again, quite a common type of phobia for people avoiding getting on planes. One option might be none of these, that you might have a particular fear that wouldn't really come into any of these categories. And for those lucky individuals out there, one option is nothing. It might be that you aren't scared of anything in particular, even mild fear of. But Laura, would it be okay to just open the options for the poll now? And we'll give you guys about, let's just give it 30 seconds or so to get some data in, and then I'll ask Laura to refresh and we'll see what range of options we come up with. So that's interesting that there's a minority of you guys saying nothing and a majority being scared of at least one of those other areas.
And we were discussing before, we had a prediction, and what was going to be the most common, and I thought social situations might be even higher than that. But actually it's animals and insects, so whether it's spiders, snakes, dogs.
Yeah, interesting.
Yeah.
Yeah, well, I think we were definitely assuming that social situations would be up there, but it looks like animals or insects is a more common fear for you guys. Okay.
But I guess what it really shows overall is that there weren't many of you who said nothing. That's only 8%, and everybody else that's had something. So it's completely common and normal to have fears and to be anxious about something.
Yeah, and if you guys keep your answers in mind for this poll, we'll be kind of building on them with a second poll in a little while.
So having had to think about phobias and what they mean, I just want to move on to think about how we actually develop phobias. So I'm going to start by showing you a really cute little fluffy rabbit, and I'm going to ask, is anyone scared of this? And I think probably the answer will be no, and we are really pre-wired not to be scared of these cute little animals like this. We are pre-wired to be scared of things like snakes and spiders, and there's obviously evolutionary reasons for that it was a good survival technique to avoid and run away from potentially dangerous animals. So probably not many people will be scared of this. But I want you to have a think about, what if you as a child were once badly bitten or scratched by a rabbit? Maybe you'd see this.
Demon buddy.
Demon rabbit. So just in this kind of way, I want just to have a think about how a phobia can develop. So imagine, as I say, you were once badly bitten by a rabbit. It hurt, you didn't like it, you felt scared. So next time you see a rabbit, you're likely to remember the event of being bitten and not liking it. And you remember that you had the automatic reaction to feel scared by it. Now, for most people, they will have this event that they'll have, and nothing will happen. They won't develop a phobia. They'll remember it as an unpleasant incident, but they won't develop anxiety. But for some people, they will pair seeing this neutral stimulus of a rabbit with the feeling of being scared. So they'll automatically respond to seeing the rabbit by the emotion of fear. And it becomes like an automatic pairing.
Mm-hmm. Yeah, it really speaks to how our brains learn information. Our brains are made to learn by association. So I don't know if anybody's had the experience of a certain song coming on the radio, and all of a sudden it's like you're transported back to that moment in time where you first heard it. It's because you will have associated that piece of music with that particular experience. And in the same way, we can develop phobias. So something neutral like a cute fluffy bunny, if you can associate that with quite nasty pain or anxiety, then just the presence of the fluffy bunny will cause that it will cause the automatic response, but it will become learned. So something that should just be neutral can become associated with something much more anxiety provoking.
And there might be other factors, other things for keeping the problem going or keep a phobia developing. For instance, your family know that you're scared of rabbits, so keep you away from them or keep them away from you. You start to generalize out from this fear of rabbits potentially to other animals. Maybe it starts with other rodents, guinea pigs, hamsters, or it might move on to dogs or cats, but it sort of generalizes across under one thing. Then you might start to think that actually you're the kind of person that's not good at coping with things, that you're not a confident person, and you might start to lose a bit of your confidence in that way. You would definitely turn over the channel if Watership Down is on. And if any of you have seen the original version, that is not a children's film.
It should not be a children's film. It is genuinely terrifying.
Traumatic. And of course, rabbits don't come into our everyday life very much, so that's okay. You can get to school and work and get on with life. You might have a rabbit phobia, but it might not interrupt your everyday life, so you can manage with that fine. But what if the phobia was about something that does get in the way of your life?
So that kind of leads us neatly on to blood injury and injection phobia, which is kind of type of phobia that can be a little bit more life-limiting than an animal that you might not come across very often. So I guess we're going to explain about this a little bit more, but the same principles of association can also explain why people can develop phobias of needles, which are quite neutral objects on their own. And for somebody with a blood injury and injection phobia, they will experience very high levels of anxiety in response to certain triggers. Some of those triggers are quite obvious, such as the sight of blood or wounds, but some may be to do with needles, whether it's a syringe or whether it's a cannula or a lancet. But then it can be a little bit more broader as well. So for some people, their blood injury and injection phobia could be triggered at a medical setting, so a hospital waiting room or a GP surgery, or even waiting for the dentist. Now, what's interesting about blood injury and injection phobia is that the high level of anxiety the person experiences in response to the trigger, it's the only anxiety disorder where people can typically faint quite routinely. So in most anxiety disorders, most other anxiety disorders, what can happen is a person will typically have the adrenaline response in their body when they're anxious, their heart will beat faster, their breathing will increase, and their blood pressure will rise. That may make them feel a bit dizzy or lightheaded, but it's physiologically impossible for them to faint because their blood pressure has been raised. It's a little bit different in blood injury and injection phobia though, because what can happen is you'll get an initial rise in anxiety, but then your blood pressure can actually drop quite dramatically, quite quickly. It's something called vasovagal syncope, and we're not 100% sure why it happens, but there's a couple of theories out there from an evolutionary perspective. And it kind of makes sense if you've sustained a wound and you're bleeding. If your body lowers its blood pressure, then you will lose blood slower and your chances of survival will increase. So I think that's probably the closest explanation we have as to why people faint at the sight of blood and needles, but not in other anxiety contexts. It's just kind of what we've been touching on there. And again, the principles of association explain the development of blood injury and injection phobia. So there are some events that would just evoke an automatic response. If you find yourself bleeding heavily, you're going to feel scared or anxious, you're going to be flooded with adrenaline. And it makes sense from a survival perspective why that event would cause that automatic response. That response of feeling scared is likely to provoke some action in you, fight or flight, increasing your chances of survival. But because of association, it's possible to pair a neutral stimulus with this kind of unconditioned event, if you like. So a needle on its own is just an object. It's an inanimate object, it can't hurt you, and we aren't hardwired to feel scared of needles. But if you've associated the sight of a needle with bleeding or pain or distress, then over time what will happen is you'll learn to respond to just the image of a needle by feeling scared, even if you're not bleeding, even if it's not causing you pain. So again, the principles of association, they explain how we can acquire phobias, and blood injury and injection phobia is no different. But what we're finding quite interesting at the moment is why people are coming forward for treatment for blood injury and injection phobia when they are. So typically what might happen is a person can often live with their needle phobia for quite a long period of time if the cost of treating their phobia is heavier than the cost of continuing to avoid the needle. So up until relatively recently, it might be that the cost of avoiding needles may be that I can't go on holiday to certain countries if I need a vaccine, or maybe I need a dentist appointment, but I'm going to put it off. And that cost might be quite a small price to pay if the person is really scared of needles, and if the cost of treating the phobia would be having to face severe levels of anxiety and take a lot of time, energy, and effort to actually overcome the phobia. So for as long as the cost of treating the phobia is heavier than the cost of continuing to avoid needles, people don't come forward to treatment. But as we all know, for the last couple of years, these aren't ordinary times that we're living in. The COVID pandemic has caused a bit of a paradigm shift in lots of different ways. And all of a sudden, there is the necessity to have a COVID vaccine. And that has completely tipped the scales in the other direction for a lot of people. So all of a sudden, the cost of avoiding needles includes the cost of avoiding the COVID vaccine. And that can mean a higher chance of getting COVID severely. It can mean being more at risk to your family and friends and loved ones. It can mean travel restrictions. It can mean being unable to access certain venues or businesses if you haven't received your vaccinations, or even in certain healthcare roles, being faced with dismissal if you refuse to get vaccinated. So all of a sudden, where the cost of avoiding needles has grown dramatically because of the pandemic, and it's greatly outweighing the cost of having to face the anxiety in overcoming it. And that's why we're seeing quite a lot more people come forward to clinics like ours to ask for help, and why we're going to, I think, explain a little bit about that pathway later in this discussion. So we'll do our second poll now. With that being said, what I'd like you guys to think about is the answer to the first poll that you did, what you were scared of. What we're really interested in at the moment is the kind of impact this fear has on your day-to-day life. So the level of disruption or the level of inconvenience being scared of that object or situation causes you guys. So in a moment, Laura's going to raise the options. They're going to flash up on screen. But again, think about the answer to the previous poll and consider how much does that fear bother you? And it might be that it doesn't bother you at all. It might be that it bothers you slightly. It might be that it bothers you quite a bit, but not so much that it stops you doing anything that you want to do. It might be that it bothers you so much that you have to avoid it or situations where it might be there. And at the severe end, it might be that it bothers you to the point where you can't do anything else because of it. So I once encountered a woman who sadly was so scared of birds that she avoided leaving her home because there might be a bird at any time I went outside. So that would be the other end of the scale. But Laura, if you could please just open up the poll now, and again, we'll take another 30 seconds. Maybe you could signal when we've had a majority of responders, Laura, and we'll come back and see what people are saying. Brilliant, thank you very much, Laura. Let's see what people are coming back. Okay, so the majority, it bothers you slightly and it bothers you a lot, but it doesn't get in the way of what you want to do. Interestingly, a fifth of you, 20%, are saying it bothers you so much that you have to avoid it. But so when we were discussing this before, we were assuming that the vast majority would either be saying not at all or bothers you slightly. So it looks like the distribution is a little bit further towards the stronger end than we were expecting.
So hopefully, we were just having a little peek at some of your questions. Well, hopefully the next part of the talk will answer a little bit about what to do if you have got worries that are getting in the way of life. Yeah, we're going to explain a bit about how treatment for phobias works, and at the very end we'll be able to provide you with some information for services if this is of interest to you. Okay. So we're moving on to the point, a bit that's most interesting, which is how you actually get better from phobia, how we treat it through talking therapy such as CBT. So briefly to kind of let you know about cognitive behaviour therapy and how it works, just very briefly, the basic principles of it. It's two people looking at how the world works together, and one person is an expert in CBT, like Stephen, and one person is an expert in their own problems. So you're sitting with a client who knows their own difficulties, how it gets in the way of their life, and you have, as an expert CBT, have the techniques to help them understand and frame their problems. And with anxiety, which phobia is a kind of anxiety, what we're really trying to do is help the client to test out if the world or the object or the situation is as dangerous as I actually believe it to be. And we always do it collaboratively. We don't tell people what to do. We set up a rationale for why we're asking them to do it, why we'd want them to do it. And we always do everything together, and we never ask clients to do things that we wouldn't do ourselves. So Stephen and I were just reflecting before about some of the strange things that we've done, such as with social anxiety, I had to faint in Phoenix to demonstrate to the client that actually it was pretty embarrassing, but you know what, it wasn't the end of the world, it wasn't catastrophic. So we end up doing kind of these odd things. That's what's interesting about being a psychologist. I recommend it as a career. And it's not about giving reassurance, because you probably all know in your lives as well that reassurance makes you feel better briefly, but then it doesn't really help in the long term. So we're not there to kind of give reassurance, but just encouragement. And we ask people to keep an open mind. I think CBT, it's not something that's done to the person. It's being given a tool that they learn to pick up and use for themselves. Absolutely, yeah. We become redundant by the end of treatment, which is ideal. So the main principles of CBT that we use for anxiety disorders, including phobias, is something called exposure therapy. And what that actually means is that we want to work with the client to allow them to expose themselves to the anxiety they're feeling. And a lot of people are scared of anxiety, they're frightened of it, they don't know how far it can get before they might go mad or explode. But we know that, you know, anxiety is horrible. We were sitting here looking at the numbers going up and we could feel our anxiety rising, how many people were sitting in the room, in the online room. And, you know, exams, interviews, they're all anxiety provoking and unpleasant, but they're not it's not dangerous and it will pass. And so what we do with phobia with a client is we are together sit down and work out the examples that they're scared of related to the phobia, and we'll give some practical examples of this in a minute. And then we arrange these examples in a hierarchy, a sort of step ladder, from the least scary, so the easiest thing to do, to the most scary. And they might start the sessions looking at the top and thinking, I'll never get there, but we gradually step through it together. And the aim is that we ask them to get used to each step until our anxiety drops. So we wait as long as they need to till our anxiety starts dropping, and we ask them to stay with the anxiety and not avoid it and not distract themselves. And the technical term for that is called graded exposure. Yeah, the way that our brains are wired, if you spend long enough in the presence of any stimulus, eventually your brain will just get used to it and you'll get bored of it. It's a good example to think about is if you imagine your favorite stand-up comedian, and if you were to watch, say, a 2-minute video of them doing their best material, telling their funniest jokes, and if you asked yourself at the end of that 2 minutes, how funny was that clip? And then you watched it again and asked the same question, and then you watched it again and you watched it again, what would probably start to happen is sooner or later that clip is going to get less funny. And it's not that you're doing anything to decide for it to be less funny. You're not doing anything to try and turn down the funny. It's just that your brain has naturally got used to the image on screen and the sound. And in the same way, we can get used to things that scare us, things that would normally make us avoid and escape. We can, through exposure therapy, just train our brains to desensitize themselves to whatever it is that we need them to. Absolutely. And so what this is called is habituation, which is a technical term for that we know that our anxiety to the thing we're scared of will just naturally decrease if we see it again and again and again. So an example might be the first day in high school or in a new job where your anxiety will be up here and then it'll gradually reduce over time. So by the end of it, it's just a very normal habitual thing you're doing. And what we really want with the client is, if they're scared of something, is that they'll get actually so habituated they're bored by it in the end. And we know that we can train the brain to learn to respond differently to things that we were previously scared of. And simply put, our brains get used to anything if they're encountered for long enough. So as Stephen said, something that was funny initially will get less funny over time. Things will get less scary, things get less exciting. If you stay with it for long enough, the anxiety will just gradually reduce. Yes, the bottom line is our emotions decay naturally when we feel them. Yes. Emotions aren't designed to last forever. And what can often keep unpleasant feelings going is when we try to avoid feeling them. We get temporary relief, but then they come back later. If we can learn to just sit with our feelings, over time, those feelings will naturally die down. And so just to give you an example of something that lots of us are scared of, I'm not very keen on them myself, spiders. This is an example of, if you're working with somebody with spider phobia, an example of a kind of hierarchy that you might do with them. And remember that we'd be asking the client to sit with each stage of this till they get used to it. So you might start with a picture of a cute, funny cartoon spider. Then you might move up to a video of a small spider, then a video of a tarantula. And again, just sitting until the anxiety drops. And these sessions can take hours or repeated. We might ask people to go away and do it at home as well, because actually it can be quite long periods. Yeah. I say we do funny things as therapists. We do have to go and find spiders and put them in jars and get them to kind of used to getting closer to people, to the clients. We might then put them on the desk near them, then ask them to hold it, and eventually moving up to the really scary stuff, holding a live spider and even holding a tarantula. And the beauty of it is that you stay at any level on that ladder long enough and it will get boring. So if you're at the bottom looking up thinking I could never hold a tarantula, by the time you've got used to each of those steps, holding a tarantula won't be as scary. It won't bother you as much. So this is just a pictorial example of a couple of pictures that we've used with clients. This is a pretty unscary looking spider that's but still can trigger anxiety for people who have a proper real spider phobia. So we might start with this step. We might move on to something a little more aversive, a real spider. And then for the next one, I'm just a bit of a trigger warning. If you are scared of spiders, you don't like them, look away now, because it's rather an unpleasant photograph of a spider. Okay, so look away now.
Yeah.
Yes. Okay, that's at the top of the hierarchy. So I'm going to move off that. So spider.
Yeah. Why would you do that?
Unpleasant spider picture has now gone.
Okay. We wanted, again, just thinking a little bit more about how habituation works. So as we've kind of been exploring so far, this graph would represent, the y-axis would represent the level of anxiety a person experiences when they encounter their fear, and the x-axis will represent how long they spend in the presence of that thing they're scared of. And what usually happens when a person is scared of, well, when they encounter their phobia, which, oops, there we are, sorry, it's jumping back there. If they encounter, say, for example, a needle and blood injury, needle phobia, what happens is their anxiety will shoot up very quickly. So they'll feel very anxious very quickly. And the natural reaction to feeling anxious quickly is to escape it and avoid it and do whatever you can to get away from the thing that scares you. So that's what we do. We escape or avoid. And in the short term, our anxiety will come down very, very quickly. So avoidance is a very effective way of mitigating your anxiety within a few seconds or minutes when you're feeling scared. But the problem is that all it really does is kick the can down the road, so to speak. It doesn't treat the underlying fear. And the next time you encounter the stimulus, which in this case is the needle, your anxiety will be just as high. So you'll avoid it again and you'll get relief. But then you encounter another needle, and so on and so on. And people can live on this zigzag line perpetually. If every time they encounter something they're scared of, they avoid it, they get relief, but it doesn't really deal with the underlying fear. Now, by contrast, with exposure therapy, if you decide to spend time for a prolonged period of time in the presence of the thing you're scared of, your anxiety will go just as high or maybe even a bit higher to start with. But over time, you'll see it gradually reduce. The key word there being gradually. This is not a quick change like avoidance and getting away from it fast. It takes time. It might take several minutes or several hours, but sooner or later, fear levels will drop.
And it's unpleasant, isn't it? Because being anxious is unpleasant and sitting with it.
Absolutely. But the other thing to think about is not just doing it for long enough, but repeatedly doing it. What we see over time is that if you repeat exposure again and again, each time the anxiety might get a little less intense and it might disappear a little bit faster. And over time, we start to see relationships like this green line, where through exposure therapy, the level of anxiety will be lower and how long it will last will be quicker. And that's much more effective than the zigzag line. So I guess the difference is if we avoid things we're scared of, that's kind of like a short-term gain for long-term pain. But through exposure therapy, it's the opposite. It's short-term pain of having to face it for long-term gain of getting over the fear. So one of the main ways exposure therapy works, as we say, is through this phenomenon known as habituation. And a graded hierarchy for phobias, in the same way that Claire was explaining about spiders, can involve pictures and videos, getting increasingly graphic. It can involve fake needles or real needles as props, holding them to your skin. And then we get into using things like lancets or finger pricks to actually draw blood from ourselves and the clients in the therapy room, or even giving them an injection with a needle that's sterile. And I guess that, we wouldn't do anything to patients that we wouldn't do to ourselves. And in the controlled environment of a therapy room, we actually would break the skin, we would draw blood, all in the name of exposure therapy. So you can often walk out of an exposure session feeling like a human pincushion. But again, each one of those levels on that hierarchy gets boring and dull when you and the patient spend long enough in the presence of it. Now, the other way that exposure therapy helps to treat the phobia links back in more to one of the fundamental principles of CBT. And in CBT, we're really interested in how our thoughts affect the way that we feel. So our emotions aren't coincidental. We feel a particular way when we think a particular thought. So For somebody who doesn't have a needle phobia, they will have very different thoughts about getting an injection for somebody who does. And beliefs that a person with a phobia might have about needles would be things like, I won't be able to handle the pain, or the injection could have something in it that could make me seriously ill. Maybe I'll faint and never regain consciousness. Maybe my anxiety will get so severe that I'll lose control, or maybe the head of the needle could break off and enter my bloodstream. Maybe I'll break down and it'll be incredibly humiliating. Now, for somebody who doesn't have a phobia, these thoughts may not seem very convincing, but for somebody with a phobia, these thoughts will be completely convincing, and they'll just treat them as if they're true. But thinking this way, understandably, makes the person feel very anxious. Beliefs have a huge impact on our emotions, and having the thought that I can't handle the pain will cause the person to feel scared.
And I guess it's important to remember that beliefs are flexible and can be changed. They're not facts, and often people muddle up what are beliefs with facts. So Stephen, through therapy, would try and change the beliefs and try and reduce some of the unhelpful ones. Right,
and that's right on the money, because that's exactly what can happen through exposure therapy. So when a person spends that prolonged period of time with the needle, it's not just about getting used to it. It's actually about giving them an experience in which they find out what actually happens. They can actually test their underlying beliefs. What will happen when I get an injection? Will I lose control? Will I faint? Will I go to pieces with the pain? And by going through with it and finding out, more alternative, helpful beliefs can form. So the person can go from thinking that I can't handle pain to thinking, actually, it wasn't that severe, and I can cope just fine. And in practice, this is what it looks like. So the red boxes refer to the pattern that we can fall into, or a cycle we can fall into with a phobia. The thought that this needle will make me break down and I'll be humiliated is going to make the person feel scared, which is going to make them avoid the needle, which is going to stop them from finding out what would have happened otherwise, and continue to believe that, you know what, if I had got the injection, I would have broken down and it would have been humiliating. But by contrast, when we do exposure therapy and we stay in the presence of the needle, we actually find out what happened. Maybe that person believed that I handled it better than I thought. It didn't make me break down, and it didn't make me lose control. Now that thought is going to make them feel much calmer and much less scared. And feeling calmer and less scared is going to make them more likely to stay in the presence of the needle. So these relationships between our thoughts, feelings, and behavior is really what we reflect on in CBT. And through exposure therapy, there's two mechanisms we've described: habituation and getting used to it if you spend long enough with it, but also learning to challenge the underlying beliefs through actually encountering the thing you're scared of and learning what happens.
Okay, so we've talked a lot about the theory of CBT and the theory of exposure therapy, but we thought it'd be really useful for you to see what it would look like in practice. So one of our colleagues very kindly agreed to be a client for us, very much based on the kind of clients we see in the clinic, and Stephen is going to be the therapist for it. And if you can imagine, this treatment session we're about to show is probably, they're about halfway through, they've been moving up the hierarchy, and they're just about to go to something a little bit more challenging. So it's about 6 minutes, I think.
Yeah, it's just over 5 minutes. I think it's an accurate representation of what therapy looks like. So hopefully you'll see me trying to be collaborative with our patient, Toya, and hopefully you'll see a bit of shared decision making, and hopefully a little bit of trying to get to the beliefs and trying to update them and challenge them.
And then we'll end, won't we, just with the last few slides on the clinic pathway.
But Laura, when we start the video, could you turn your camera on and give the thumbs up if the audio is coming through okay? Would that be all right?
I will do, I will. I would suggest as well everyone to have their volumes up high, because the volume on the video is quite quiet, so turn volumes high.
Yeah, unfortunately the microphone wasn't the best quality, so please turn your volume up. It is audible, but it's a little on the quiet side. Okay, Toya, so before we get started, could you explain to me a little bit about what we're about to do and your understanding of why we would do this, if that's okay?
So I know today I'm supposed to get used to seeing the sight of my own blood and to get used to that sensation of a needle prick.
Yeah.
I think the reason I'm supposed to be doing this is to get used to that and I guess help me overcome this phobia.
Does that make sense to you, what you've just explained?
I think so, it makes sense.
And this idea of getting used to things, has that been your experience of what's happened with the pictures and the videos that we've looked at so far?
Yeah, definitely. So like looking at that picture of the blood, I hated that at first, but now I'm able to tolerate it, which is better than before.
Yeah.
And looking at the needle, the same thing, really.
Right, right. And I guess my hope is that what we're about to do today would be no different. It would just be something else for us to get used to.
Yeah, in theory.
Yeah. And just to get an idea, how high is your anxiety right now on that 1 to 10 scale that we've been using?
Probably about a 7.
About a 7,
Yeah.
so pretty high.
Yeah.
Okay. Is there anything else we need to agree, or shall we just give this a try and see how it goes?
Yeah, I came here to try it, so
Okay, okay. Is there a preference for what finger you'd like to use?
this one.
Okay. So I've got an alcohol wipe here. If I give you that, would you be able to just give your finger a little clean? Okay.
Do you think it's going to hurt?
I guess that might be one of the things for us to find out, whether it hurts, and if it does, how you can react to that. So when you're ready, if you want to show me which finger you want me to use, and I'll use the lancet.
I'm feeling a bit anxious about this. Really.
Right, right.
Right.
I can understand why you would, and I guess want to remind you, when you felt anxious with some of the other exposure we've done, what's been the best way that you've found to manage that?
Basically just to sit in the situation and to just learn how to kind of tolerate it. So no matter how anxious I feel, no matter how much I want to kind of run away,
Yeah.
just to sit with it.
Okay. So with that being said, I know you're feeling anxious now. Shall we get started and just see how this goes? See what happens?
Yeah. Yeah,
Are you ready?
I think so.
Okay. So I'm just you're gonna feel a quick prick. And if you could just give your finger a little squeeze and try and see if a drop of blood appears. Can you see any blood there, Toya?
Yeah, I'm trying to squeeze it.
Okay.
Oh.
I can see a drop there.
Oh.
Okay. I know that you're really tempted to look away, but could you just stay with the image of that blood on your finger, Toya? How high is your anxiety right now on that scale?
Probably a 7 still. I
Right.
can barely look at it.
Okay. So you're doing really well. I know you want to look away. If you could just try your best to stay with that drop of blood. Just watch. Just stay with it. Are you noticing anything as you just stay with that drop of blood on your finger?
I'm not bleeding to death.
Okay. Could you say a little bit more?
My finger doesn't really hurt, so it's not as painful as I thought it would be.
How painful did you think it would be?
I thought it'd probably be on the 5 out of 10 scale for pain, but it was more like a 2.
Okay. So it's not as painful as you thought. You're not bleeding by the sounds of it as much as you thought.
It is vile though, it's disgusting.
So though it sounds like it makes you feel disgusted, it's not. Well, what is happening to your anxiety as you look at the blood?
I think it's going down, because I'm curious to see what's happening now.
Okay. What tells you that it's going down? What are you noticing?
I'm just noticing that my heart rate has kind of gone down a little bit.
Okay.
So someone's calling me, I put the phone away.
Okay.
Yeah, I feel a little bit more relaxed. I'm looking at it.
And is anything about this experience surprising to you or different from what you thought would happen?
I almost thought I wouldn't turn up to today's session.
Right, right. So I'm really glad that you're here. I'm noticing you seem to be looking away a little less often now. How would you summarize what you're noticing in the last couple of minutes of us doing this, Toya?
Well, I have been able to sit with this. And my anxiety started off up here, but like, I'm looking at it, it's not nice, it's disgusting, but it could be worse.
Okay.
Okay, so hopefully that gave you a little taste of what a session would look like in terms of trying to keep a client with the anxiety and doing something together and supporting them through that kind of step on the hierarchy. So we just want to end by just talking very briefly about what's happened at our clinic in terms of this needle phobia treatment. I'm sure you've heard people, friends, family who've not been able to receive the vaccine due to their fear of needles or blood. And we were in the clinic talking about people that we knew like that. And we sort of suddenly thought, well, actually, we know that phobias are really treatable with CBT. We can do this and do something to help it during the pandemic. And so early this year, we made it open to all staff at the university who were suffering from anxiety and weren't able to get the vaccine because of it. And there was somebody, for instance, that I saw who said that she managed to get the vaccine, was really stressed before it and after it. But actually, after she got it, she realised that this was going to have to go, she's going to get a booster, she needed a flu jab. So it wasn't going to be a one-off injection that was going to be going on, for, who knows, for years. So that's also prompted people to come and get treatments. So there's around 10 of us in the clinic, and we've assessed a small group of around 20 to 30 members of staff. We meet them individually for treatment. And we held, some people weren't happy to come in a few months ago, so they were online. Some were held in person in our clinic. We followed a brief evidence-based treatment protocol, and it consists of 3 sessions. We started off with a long kind of 90-minute assessment where we understand and find out what the beliefs were, what the problems were. We then had a long, as you can now probably see why it takes so long, some of these treatment sessions. We had one long treatment session, and then we had a follow-up session to check change and progress. And we really did what we've described here, which was exposure to anxiety, habituation, and work on their beliefs. And it was successful. We measure anxiety through self-report measures. We saw improvements of this, and we saw improvements in people's functioning behaviours. And the kind of success of this has meant that we want to continue offering this pathway for treatment for self-referral for students and staff with any kind of phobia. So we broadened it out to students as well and to any phobias, because basically it doesn't really matter what the phobia is, we treat them all the same.
Yeah, it's known as rapid exposure because it takes place in one 3-hour session, but people can really overcome their phobia in an afternoon if they go through the exposure intervention. But we wanted to just really finish on a case example, Meg. So Meg was a member of staff who accessed this pathway that Claire's described. She had her needle phobia for over 20 years. It really dated back to her experience of childhood vaccinations being really scary and other things going on at the time that meant she associated difficulties with the needle. At the start of the treatments, she was unable to get vaccinations. She was avoidant of the dentist and GPs, but she was also avoidant of any TV film that portrayed medical settings or horror or violence, and she wouldn't even really like to talk about anything biology or physiological, so anything to do with the circulation or her blood. 3 hours later, she received a number of puncture wounds through the exposure, but she got used to it, she habituated, and she learned she could handle it. Her tolerance for the anxiety grew a lot through exposure, and she was no longer scared of fainting or losing control. And actually, as a result of the treatment, not only did she get the COVID jab, she decided to become a registered blood donor. And that would mean getting a needle every 3 months, I think it is, as a way of just keeping on top of the fear. But that was her decision to do that. And it was a really nice outcome as an example of people's continuing intentions with it. But that's really all we wanted to talk about today. Thank you very much for your attention and your time. I would encourage you guys to take a quick screen grab of the slides. So we've mentioned earlier that if any of you are experiencing a phobia or indeed any other type of common mental health problem, there is support available. CBT can be accessed for free through the NHS, and the person to start with would be your GP. So booking an appointment with your doctor to find out what local services are in your area that provide CBT. We've listed the local ones in North East England, but for those of you who are attending today from other parts of the country, there will be a service in your area that provides the therapy, and you can access those adult services from the age of 16. If you're under the age of 16, then there's the children and young people services up to the age of 18, that's known as SIPs. And again, your GP can point you towards them. There are some really good 24/7 listening services, including the Samaritans and Shout, which is a text-based listening service. And finally, there's some useful websites and self-help material that we often incorporate online. So please take a screen grab, and help is available if you do need it, but it's been really good to present to you guys. Thank you for your time. And are there any questions?
Thank you so much. You will see in the Q&A box that there are many questions. That was such an interesting topic, and I'm sure it would have been a massive help to anyone who has a phobia or is just interested in this topic. And so my thoughts are, for the last 10 minutes, I'm just going to fire some questions at you, if that's okay. So I've cherry-picked a few because I know we're not going to get through them all. So the first question is, can we inherit phobias?
That's a good question, the nature-nurture debate.
Yes.
Well, I guess there are certain studies that have identified genetic links. People can be predisposed to feeling anxious more easily than other people. But in terms of a phobia, I think we would come down more on the side of it's learned rather than it's inherited.
Yeah.
You may be predisposed by your genes to feel more anxious or have a proclivity to feel more anxious, but it's really your experience and your circumstances that create those environments where you might associate the thing you're scared of with, the phobic object with an anxiety response.
Yeah.
And I think that has a much bigger impact, your actual experience and what you live through, than anything that you're predisposed to when it comes to phobias. I don't know whether you disagree.
No, that's I totally agree.
We might have just lost them there. Let's see if they come back. Sorry, you froze there, but we got the main gist of it. Thank you.
Oh, right.
There's a little bit of evidence as well that people can learn phobias from watching, say, their parents with a phobia. So if your mother has a phobia to something, you might learn that. It's called modeling.
Yeah.
So we would say it's more learned than inherited, than biological.
Excellent, thank you very much. And do you think that phobias get worse with age?
Any problem untreated will be harder to unstick the longer that you experience it for. So, we've both come from NHS backgrounds, and we work with students who are young adults now, but in the NHS, we'd often work with people right up until, 70, 80 years of age. And what would typically happen is a person who's struggled with a problem for 40 years of their life is going to take longer to recover than somebody who's had the problem for 6 months.
Partly because they've arranged their life around it, partly because they're used to avoiding and so they've kind of rearranged things around it. So that's part of the reason, I think, isn't it?
I often use the analogy of a cornfield. So having a problem untreated for a long time is like a path in a cornfield, that the more you walk it, the more it gets embedded and it becomes a permanent part of that field. Now, what it doesn't mean is that you can't walk another path in that field, but at first it's going to be really effortful. It's going to be you're going to have to take a lot of effort and time, and you're not quite sure which direction to go in. But the more you walk an alternative path, that too can become a more permanent part of the field. It doesn't mean the original path has gone away, but it does mean if you find yourself on it, there's an alternative direction that you can take. So there is always hope. There is always, room for improvement, so to speak.
And that leads on actually to another question where a few people have asked if they've had treatment and the person is feeling like they're over a phobia, can that phobia come back?
Yeah, well, I mean, it can, but we would recommend that people keep working at it. So keep on, some phobias are more difficult to treat just because they're harder to do regularly. So flying is a good one. People with flying phobia haven't had a chance to fly for 2 years, so it might creep back. So we would suggest that you can keep topping up with exposure, and even do you can do some imaginal things, or you could do some kind of more creative things if you aren't actually able to do it. But it's like we'd call it setbacks. If people have setbacks, they're not relapsing, they're just setting back, and you probably just need to work at all anxieties. You just need to work at it a little bit and keep topping up to remember why you were doing the exposure, you know?
Yeah, I think the key to ongoing mastery of a phobia is just incorporating it into everyday life. So it doesn't feel like exposure if it's just something that you do. I mean, there are things that we all do every day and every week to look after ourselves. We all eat food every day. We all have showers. We all self-care. If you look at exposure as part of self-care and incorporate it into the routine, then you stay on top of it. But I mentioned earlier that I'm a little bit wary of heights. Never used to bother me. I used to avoid heights right up until I met my wife, who's an avid climber. And then all of a sudden there was an incentive to get over my fear. Now, we used to go climbing weekly and I was on top of that fear, but then we had children and children cut into climbing time. And now I climb maybe months apart when I can get an evening to do it. What I expect every time I go back to the wall is my anxiety is going to be up again. But what's different is my confidence that it will go down if I just climb. So I think just because I feel anxious, it doesn't mean I have to listen to those feelings. What isn't important is that I feel anxious. What is important is what I learn to do with that feeling when I have it. And I think that's what we'd encourage people to think about. Just because you feel anxious, it doesn't mean that everything you've learned up to this point is back to square one again.
Excellent, thank you very much. And a question here asking, how would you go about graded exposure to bees or wasps? But I suppose that's probably quite similar to spiders, but I'll let you take the floor.
Very similar, really. Pictures, videos, watch a documentary about them. At the right time of year, you could put jam or lemonade in a jar and try and get hold of one. Well, not maybe physically, but get close to one. Just very similar, really.
I mean, depending on the person's resources, if they've got the money for it, go beekeeping. You know, anything that would make sense to get them. I'm treating somebody with a dog phobia at the moment, and we're going to a really popular local park which is flooded with dogs every single time we show up. So it's again getting out of the therapy room and into the world, really.
Excellent, thank you. And how would you overcome a fear of pain? Since exposing yourself to its situations can be harmful, would you use a different method?
That's a pain phobia.
Yeah.
It's an interesting one.
It would depend on the context, I think.
And the beliefs around it. What that's the main thing I would start to say to people. What's the bit that you're most scared about pain? Is it that you feel you couldn't cope with it? Is it that you're worried that you, I don't know,
what's so bad about pain? What do you think would happen if you felt it? So we could certainly understand the thoughts surrounding it and how to test those thoughts out. But it would really depend on what level of pain aversion. Like if this was a really strong aversion, then ethically you might, again with the person's consent and their ideas, it's possible that you could, in the therapy room, introduce pain in a controlled way that was, again, I really want to emphasize that. It would have to be consensual. It would have to be collaborative. The person would have to choose what to do. It would never be just, hitting your patient against their will. But if there's a clinical rationale for it,
a finger prick is quite painful, actually. That's quite a good one to start with. So you start with something that was safe and manageable and just build up from there, really. But it's always about the beliefs and what's driving it and what's the worst thing about it. That's what you want to try and get at.
But we wouldn't be going as far as wounding people. That's obviously, we wouldn't be damaging a person. But if pain is what they're scared of, then exposure to some pain might help them learn that the tolerance is maybe higher than they anticipated.
Excellent, thank you. And another question's come through asking if all phobias can be treated.
I haven't come across one that hasn't. I mean, really, all anxiety problems, all phobias are different flavors. If you think of an ice cream, it almost doesn't matter to us what the phobia is. Some are easier. Dogs are quite easy because they're around a lot. Some are more difficult just because they're slightly harder. So, I mean, I work with OCD quite a lot, and some people's religious OCD is about death and hell, and they'll go to hell, and you have to be quite creative when you're actually trying to test out something and use imaginal stuff. So it doesn't really matter in a way what the phobia is. We would just try and think creatively about how we can get people to expose to the anxiety around it.
The fundamental principles would apply whatever the phobia is. If I'm scared and I avoid it, that fear gets perpetuated further along the line. If I'm scared and I confront it, sooner or later my fear level is going to come down. And I think whatever the source of that fear, it can be treated in the same way.
Excellent, thank you. And the last question of the night is, what are your favourite aspects of your job? You know, why have you gone into this career?
Ooh, good question. Do you want to go?
Shall I go first? Okay. I love working with anxiety disorders, and particularly OCD and health anxiety, because people can get 100% better from them. People absolutely, it can, you know, transform their lives. And I'm really passionate about, with anxiety disorders, is often just an error of thinking.
Yeah.
People have misinterpreted the world. They to think that thoughts are more meaningful than they are. Oh, did I?
Sorry, you froze again. You froze again.
Sorry.
The wonders of technology. But you were halfway through there.
Just saying how people can get 100% better from anxiety problems, because it is just a misinterpretation of their thoughts. And so that for me is the kind of most exciting thing about it, is working with somebody who can get 100% better from anxiety.
Yeah, I think I'd echo that really. When people engage in therapy, it really can be life-changing. It's really rewarding being part of a person's journey out of a disorder that's crippled their life, really. And you know, there's people that I've worked with over the years where, as Claire put it, you know, when we use CBT, we're helping people understand their anxiety or their depression as a thinking problem. It's it's an error in their thinking that can be relearned, and it can really have a huge impact. And when you've kind of taken somebody from, you know, say in the case of agoraphobia, not being able to leave their house independently, to going into the busiest high streets and going into a bar, it really does feel very rewarding to be part of that journey. And it's really interesting as well. I mean,
and the best thing is when we're sacked. That is genuinely the best thing, when they say, do you know, I can hear your voice in my head now saying, do this, and then I don't need you anymore. They always feel bad saying, I'm like, no, we want to be sacked.
I think on a slight side note that you touched on this earlier, but you get a lot of personal growth in this role as well. A lot of the things that you have to do to help your patients you would not do in everyday life. And I've put myself in some pretty awkward, embarrassing situations, all to help a person test out their thoughts. And I feel like that's helped my confidence grow, and not just as a clinician, but as a person. The example coming to mind, I remember working with a guy with a fear of losing confidence. He was terrified of wetting himself, and he had a very specific prediction that if I ever wet myself in public, a crowd of people would form and it would be so humiliating. And what we ended up doing was getting out a spray bottle, spraying water all over my groin, and then I walked up and down the busiest street we could find, and he stood at a distance and watched how many people noticed and whether a crowd formed. And of course, nobody did. If anybody did notice, they didn't say anything. So you do all manner of bizarre and creative things, all to help a person face their fears. And I think that does benefit you. You do grow personally as a result of that.
Well, thank you very much. What an interesting topic, and it's been really great talking to you. I'm sad that the time is up. It's really interesting. Thank you. Enjoy the rest of your evenings. Thank you very much.
Thank you very much for your time.
Bye.
Bye-bye.